ECG showed sinus rhythm was normal. Echocardiography was done. And apical two-chamber view showed mild hypokinesia في الميدوبازal inferior wall. Second mitral valve was tethered posterior leaflet and moderate to severe mitral regurg. And fair LV systolic function about 55% with dilated left atrium and left ventricle. His lab investigation was rather normal, including cardiac enzymes. So, to stabilize the patient ventricular tachycardia, the patient received IV loading cordarone, starting low dose beta blocker, and waiting for further investigation for the etiology. So, coronary angiography was done, showing atherosclerotic coronary artery disease with no significant lesion. بيقلب مش بيقلب تمام. So the next step was cardiac MRI. And this is the cine images of full chamber view showing thinned mid and basal segments of IVS. 3-chamber view. And 2-chamber. اللي بعده. The late gadolinium enhancement protocol showed transmural hyper enhancement of mid and basal segments of IVS, suggesting extensive fibrosis. T1 and T2 protocol was done, showing high signal intensity of patchy area, and prominent hilar lymph node was seen in axial cine images. So, what is the most likely diagnosis of this case, and what is the next step? Thank you. Waiting for you in the clinical case wrap up after our professor lecture, inshallah.
Just to start, like my first question, it's like it can arrive up later on. This is a very late presentation, and it's not really kind of like does not really mean that we jump to the diagnosis of cardiac sarcoidosis, which is it's a good case to start with, but it's not really the guidelines. Cardiac sarcoidosis have a very the early onset, usually in the 30s and 40s, and the ECGs you showed says monomorphic ventricular tachycardia does not indicate this is, unexplained ventricular tachycardia. The pattern of late gadolinium enhancement by itself does not indicate this cardiac sarcoidosis. By all means, I can argue, by cardiac MRI, yes, it is probably cardiac sarcoidosis, but by all means, I can argue this is not the final diagnosis, but I'll come back to this point later on. So that's, I'm the director of cardiovascular imaging in Mercy Health System in Ohio. I'll go further quickly here, giving a good, just an overview of cardiac sarcoidosis and the importance of diagnosing cardiac sarcoidosis and as part of the spectrum of systemic sarcoidosis, and the advanced imaging techniques, PET, CT, PET MRI, and we will end up with some case studies in conclusion here. It's interesting when you go, well, these presentations are created actually by the AI. So you type AI and just cardiac sarcoidosis, it will give you an outline and you put your input and papers and everything else in there. So sarcoidosis is an immune-mediated disorder, and you can imagine it affecting multiple organs, including the eye, the skin, the brain, and of course the heart. The heart is a difficult part actually to diagnose. And also the prevalence of the disease varies greatly between, it has what called like mainly the African American and the Scandinavian origin and the Japan. So we have some weather-related issues. We have genetic susceptibility to diagnose cardiac sarcoidosis. And as we said, the disease onset is usually starting at a younger age, and also the outcome from the disease also depend on the age and the presentation and the prevalence of the disease in different societies. So 70% diagnosed between 25 to 45 years of age. At initial presentation, the genetic and environmental susceptibilities. And as we said, the Scandinavian origin, Japan, and African American are the most commonly affected. And mostly, we have to have an extra cardiac sarcoidosis to suspect cardiac sarcoidosis. So basically, isolated cardiac sarcoidosis is a very difficult diagnosis, very challenging. The Japanese Society of Circulation, I will come to this slide later on, has 4 out of 5 cardiac presentations to call cardiac sarcoidosis as a final diagnosis. The pulmonary sarcoidosis is what was galaxy signs, and usually we start with pulmonary sarcoidosis. Most of the patients already have a CT, and pulmonary sarcoidosis is the hallmark of the extra cardiac sarcoidosis you can find. Of course, the skin lesions and the eye lesions are very common because they are like very clear at presentation. So why we care about cardiac sarcoidosis? Because 25% of patients with cardiac sarcoidosis have higher events, and in the Japanese Society of Circulation is that 58% of systemic sarcoidosis have cardiac sarcoidosis. Cardiac sarcoidosis represents for 1/4 of sudden cardiac death in patients with systemic sarcoidosis. And we have, the diagnosis, as we said, it's very challenging, and I'll come to this slide later on. It has a variety of symptoms, like just ranging between very non-specific symptoms, and this has to do with what system is affected. Mainly, the cardiac sarcoidosis affects the electrical system, as you presented this case of ventricular tachycardia, but more commonly actually is a high-grade AV block. So patient comes with dizziness, lightheadedness, fatigue, and so on and so forth. This presentation of like extreme dizziness and sudden death is kind of rare. And sometimes we actually make the diagnosis of cardiac sarcoidosis after implanting the ICD. So patients surviving sudden cardiac death from ventricular tachycardia or ventricular fibrillation, and then you go back and find out why this has happened. You diagnose cardiac sarcoidosis retrograde. In fact, there is a very nice study outcome also to it, which is diagnostic cardiac sarcoidosis with autopsy, and we do a lot of autopsy. I mean, every single unexplained death in the United States has an autopsy to be done. So about 12 to 62% of the patients have cardiac abnormalities, including conduction abnormalities. Supraventricular tachycardia is common, and it has to do with the fact this is an infiltrative disease. Infiltrative disease meaning the left ventricular diastolic pressure is high, the left atrium is dilated, the left atrium ends up with a scarring because of the expansion, and this will cause supraventricular tachycardia, most commonly actually ectopic atrial tachycardia, atrial fibrillation, rather than the traditional AVNRT that we see, what called paroxysmal supraventricular tachycardia. Ventricular arrhythmia, they are the most dangerous one, ranging between monomorphic ventricular tachycardia into ventricular fibrillation. Monomorphic ventricular tachycardia in a patient with normal ejection fraction are kind of sustainable because it drives the patient into the emergency room no matter what, and it will be fine, and whether the patient gets shocked or not. And this is actually where we can diagnose cardiac sarcoidosis retrogradely. And as you know that from the mechanism of arrhythmia, in every single arrhythmia, it's either an enhanced automaticity or we have re-entry arrhythmia. This is one of very classic of the re-entry arrhythmia. So their ventricular tachycardia not necessarily actually has to be very fast. It depends on how long of the electrical activity goes around the scar tissue, and that's actually got surprised. Whenever I hear a heart rate of 150, I will call this a ventricular flutter, atrial flutter with apparent conduction. So that's why it makes me a little bit not comfortable with calling this ventricular tachycardia. And then we have heart failure. When patient presenting with heart failure have bad prognosis in the to start with, because you can imagine most of the ventricular myocardium has replaced by scar tissue. And then we have, among the valvular abnormalities, we have mitral regurgitation, which is like one of these supporting in the cardiac MRI. Mitral regurgitation actually, in this scenario, is not related to tethering. It is actually related to papillary muscle dysfunction. The epidemiology of cardiac sarcoidosis is 25% of have isolated cardiac sarcoidosis. Patients with isolated cardiac sarcoidosis have LV systolic function at presentation, compared with patients with systemic sarcoidosis that you are screening them for cardiac sarcoidosis. The diagnosis is very challenging because the only definitive diagnosis is endomyocardial biopsy, which honestly, even the United States, we're not doing it that much because of the patchy nature of the disease. And not only this, it does not respect anatomy, and it does not respect even layering of the myocardium. So sometimes you find epicardial scar, sometimes you find mid-myocardial scar, sometimes you find more RV, or LV more than RV. It's very rarely actually the subendocardial area, the subendocardial area, which it's accessible for the endomyocardial biopsy. That's why we are counting a lot on cardiac MRI and cardiac PET scan for diagnosis of cardiac sarcoidosis. And the prognosis, as we said, once you have isolated cardiac sarcoidosis, the prognosis is really bad because now we're talking about heart failure and sudden cardiac death from arrhythmia. Here is the point: we have to have an extra cardiac sarcoidosis, the key for suspecting, to screen the patient for cardiac sarcoidosis. The other option is patient presenting with ventricular tachycardia unexplained, and you go back and you make a retrograde diagnosis of cardiac sarcoidosis. The cardiac abnormalities are very non-specific. With our ECG, you find some T-wave abnormality, P-wave, the P-wave showing enlarged left atrium. You find signal average ECG. We don't do it much, but we can find QT dispersion, which is an indication for ventricular arrhythmia. And then we have the Holter. We're looking for supraventricular and ventricular arrhythmia, as we mentioned before. The echo findings are not specific, which is mainly this basal septal thinning. When initially in the disease, it's actually a basal septal hypertrophy because of the edema and inflammation. And sometimes we'll find focal aneurysms. Now it comes to this, the yield from the endomyocardial biopsy. As I said, it's very low. And this is the classic one. Sorry. And that's why this is from the Japanese Society of Circulation, and they have a lot to do with because of the prevalence of the disease. So their contribution to the diagnostic nature of the disease is very important here. So if you have an extracardiac sarcoidosis, you made it easy. You end up, the first step is endomyocardial biopsy, knowing that the yield is not high. If you have a tissue diagnosis, you're done. You have cardiac sarcoidosis. If you don't have an endomyocardial biopsy, it came back negative, you have to have more than two major criteria. And if you have no extracardiac sarcoidosis, you have to have 4 out of 5 of the diagnostic criteria listed below, including positive PET FDG, and we have now hyper PET MRI and PET CT. So these major criteria are heart block, fetal ventricular arrhythmia, basal interventricular thinning, which is the only feature present actually in this cardiac MRI, and we have abnormal motion abnormalities. These are only still 1 factor there, not 5 factors. So we made the diagnosis. I would support your case only because the finding of the lymph nodes during the scan. So I'll move on to the how extensive the disease can be, this is from, kind of diagnostic criteria. Endomyocardial biopsy, arrhythmia, we went through this part. There's a nice post-mortem study that we discussed before. It does not, that these cases does not respect the anatomy, does not respect the layering of the myocardial involvement. So, but most of the cases actually that's bad enough are mainly affecting the septum and right ventricle. Once you have the septum and right ventricle, and these are like kind of like result in a fetal arrhythmia more than anything else. And the disease range from a very nice small spot here in the area, whereas typical, epicardial fibrosis in the ganglion and the ganglion enhancement in the for most of the ventricle. But involvement of the anteroseptal wall and the area and at the insertion of the anterior right ventricle is critical for the diagnosis. The second part will put the triangular area, which is again the insertion of the infraseptal wall at the insertion of the right ventricle. Here's how we diagnose cardiac sarcoidosis by PET scan. We match perfusion and FG uptake. So that the first set, which is normal, you have normal perfusion. The second set, which is the bottom line, so the FG is basically there's no FDG uptake, it's good. And the second image, actually there's a good uniform FDG uptake. This is not abnormal because mainly because we did not able to suppress the normal myocardium uptake. And the preparation for this is so difficult. You have to have a glucose-free diet for about 18 hours. It's a high-fat diet and just water for more than 18 hours to suppress the myocardial uptake. And sometimes you have to give heparin to suppress myocardial uptake. So the first two images were normal. And then we're looking at some abnormalities which are mismatched between the myocardial perfusion and the FG uptake. So is it the inflammation or the scar that's more important in prognosis of cardiac sarcoidosis? And here is one of the nice studies that tried to answer this in 2014, and there's an extension of the study in 2022. I'll present it later, actually after this slide. And this is all the late gadolinium enhancement are scar tissue. So basically, the higher the scar burden, the higher the death rate. But look at this. If you look at the slides, the RV, the late gadolinium enhancement, is more important even than the LV. The RV wall is very thin, and it actually generates a lot of ventricular arrhythmia, including ventricular tachycardia and ventricular fibrillation. And this scar burden of 6% is very small, by the way. It's not really high. If you compare this scar burden to patients with hypertrophic cardiomyopathy, the scar burden is only predictive of sudden death if it exceeds 25% of the myocardium. So this is like if in the standard practice in the United States, if the patient has ejection fraction less than 35%, even whether they're ischemic, non-ischemic, caused by sarcoidosis, caused by nothing, they require ICD anyway. Once the EF drops, the EF in the middle range, it's kind of like questionable. Once the EF above that 50%, you can see even the scar burden is predictive of sudden cardiac death, even in a normal ejection fraction. Skip this part here. This was one of the protocol we used. It's called wideband late gadolinium enhancement, and we use it for patients with defibrillator, just to remove the artifact caused by the defibrillator. How the PET scan can differentiate between as a prognostic value. We classify the PET scans: normal perfusion, normal uptake, FDG, which is like you can see that the first line, the prognosis is very good. When you have a mismatch, you have bad prognosis. This is the log rank for patients for if you have is it the scar or is it inflammation, and it's actually turned out to be the scar that's more important than anything. Why? Because when you find an inflammation, you start treatment earlier. Once you start treatment earlier, now we have a better prognosis compared to having the scar tissue. One here, we use TT2 imaging for identification of edema. And again, this is like a good prognostic sign. Once you have an active inflammation, you start. And this, the diagnosis is important because it's far beyond the cardiology medicines that we use. It's a steroid and immunosuppressive therapy. Again, we have the hybrid now. We have hybrid PET and hybrid CT that we can combine the images and find out if they are scar or if they have the inflammation only. This part here. This is my last slide by the American Society of Nuclear Cardiology about diagnosis cardiac sarcoidosis and prognostic value of PET and CT. Okay. Thank you.
The question for myself بعد إذن حضرتك, because I'm a clinical pathologist, immunologist, so sarcoidosis is a very important area of interest. حضرتك قلت which is more important, inflammation or the scar. In our point of view, the inflammation is the most serious something because it ends up with the fibrosis and with the scar formation. So what's your opinion on that?
It's just like when we have an inflammation, we have more ones to start treatment. So from the prognostic value, we actually we like inflammation more than the scar.
Yeah, because it's
already done.
Yeah, it's preventable. You mean that inflammation is preventable? We can reverse it with anti-inflammatory.
Yeah, in fact, we actually, there's a very nice study about VT ablation when you have an inflammation versus waiting until they have a scar already.
Yes.
And you do a VT ablation with a scar.
Yes, that's it. Thank you very much. في أي سؤال تاني لحضراتكم؟ اتفضل.
Viral infection can trigger this abnormal reaction?
No, this is myocarditis case. This is actually what I'm going to end up saying. The case presented is acute myocarditis and the scar is a myocarditis case rather than, unless you have a tissue diagnosis of an extracardiac sarcoidosis, meaning you got this lymph node out and you just have non-caseating granuloma there. But the COVID-19 infection may have triggered myocarditis. Remember, even in the presenting, she mentioned that cardiac enzymes are completely normal. This does not even meet criteria for a viral myocarditis caused by COVID-19.
Viral infection can trigger an acute inflammation and trigger sarcoidosis in late aging.
So it can trigger inflammation, it can trigger an immune response, but the sarcoidosis is unique. The sarcoidosis is the only non-caseating, or actually the most known non-caseating granuloma. Once you see it under the microscope, it's so different than other granulomatous disease caused by the immune system. And of course she can't correct
زي ما حضرتك عارفة احنا بنخاف من الاميون سيستم لأن هو more injurious than any virus or bacteria. الاميون ريسبونس بتبقى هي الانجوريوس، هي الهازاردس. فطبعا احنا بنخاف من الاميون سيستم جدا. لازم تخافوا مني عشان immunology. Okay, thank you very much, Dr. Ali. Very interesting. Our next speaker is Dr. Muhammad Sami from Al-Azhar. هيكلمنا عن ال incidence of sudden cardiac death and life-threatening arrhythmias in clinically manifest cardiac sarcoidosis. تفضل يا دكتور.
Thank you, Dr. Sama. بسم الله الرحمن الرحيم. I'm honored to be here with my colleague Professor discussing such hot topic, arrhythmia and sudden cardiac death in those with manifest cardiac sarcoidosis. Okay, we will begin by the pathophysiology. Early granulomatous formation and myocardial inflammation may take decades till clinical picture appears. Hence, once myocardial edema develops, we may get conduction abnormality. As the disease progressed, myocardial fibrosis may lead to ventricular arrhythmia. LV remodeling will lead to heart failure later on. So the sequelae of cardiac sarcoidosis most commonly is conduction abnormalities followed by ventricular arrhythmia and end by heart failure. Actually, electrophysiologists have critical role in management of cardiac sarcoidosis. That's because arrhythmia is the main manifestation of cardiac sarcoidosis. We can get AV block up to half of patients, a bundle branch block, supraventricular arrhythmia, ventricular arrhythmia. Besides that, heart failure is one of the main manifestations of cardiac sarcoidosis. So, cardiac sarcoidosis is an electrophysiologist disease, and our rule is early detection of the disease. Once we can give immunosuppression to hinder the progress of the disease. We will start with the heart block. Actually, in young ages, unexplained heart block should trigger the suspicion of cardiac sarcoidosis. It may follow different course, may be quick course due to edema proximal to the His bundle, or may be very slow course due to progressive fibrosis of the interventricular septum. The good news is that early immune suppression may hinder the heart block. If it occurred, we should consider either CRTD therapy or ICD therapy. The second common arrhythmia is atrial arrhythmia. It's common in cardiac sarcoidosis but less frequent than ventricular arrhythmia. By far, the most common presentation is atrial fibrillation that's caused by the atrial scarring, raised intra-atrial pressure due to heart failure, or pulmonary hypertension due to lung sarcoidosis. Atrial tachycardia comes next, then atrial flutter, and rarely atrioventricular reentrant tachycardia. And it's logic to find atrial arrhythmia more common in those with more extensive scarring detected by late gadolinium enhancement versus those without atrial scar. And this is a nice case of a patient diagnosed with cardiac sarcoidosis, developed recurrent episodes of atrial fibrillation. Once we started immune therapy, atrial fibrillation episode stopped, and on weaning of the immunosuppression, it recurred again. So starting again the immunosuppression, and this is a marker of immune process causing the atrial arrhythmia. Now, regarding the ventricular arrhythmia, different mechanisms encountered in such arrhythmia, both triggered activity and abnormal automaticity may have a role early in the disease during inflammation, causing frequent BVCs, non-reentrant ventricular tachycardia. But the most common encountered mechanism is macro-reentrant tachycardia, depends on the myocardial scar. And actually, the scar in cardiac sarcoidosis is heterogeneous, cause diffuse myocardial involvement, affecting both RV, LV in equal arms, both septum and free wall, myocardium, epicardium, and endomyocardium. And not only this, the disease progress. As we go in time, more scars develop. And in this autopsy, we can see the surviving microchannel within the dense scar. The surviving microchannel may cause ventricular tachycardia or even ventricular fibrillation. And it's more complicated. Taking 3D dimensional view, we can see the extent inside the myocardium, make it more difficult to ablate. Septal and myocardial scarring have important role. The septal scarring may cause fascicular VT and fascicular triggered VF. Mid-myocardial scarring makes the ablation difficult and need non-standard ablation protocols. And one of the challenging things is cardiac sarcoidosis may mimic arrhythmogenic RV cardiomyopathy. Regarding the epsilon wave, may fulfill task force criteria for diagnosis of arrhythmogenic cardiomyopathy. On one registry, the estimated misdiagnosed cases with 15% of patients diagnosed with arrhythmogenic cardiomyopathy actually have cardiac sarcoidosis. And on the other hand, none of patients with cardiac sarcoidosis was diagnosed with arrhythmogenic RV cardiomyopathy. And on the right panel, we can see a case diagnosed as arrhythmogenic cardiomyopathy, and after heart transplantation and during autopsy, it revealed granulomatous cardiac sarcoidosis. But there is unique aspect within cardiac sarcoidosis make it we can use it to differentiate from arrhythmogenic cardiomyopathy. The extra cardiac involvement, lung, skin, hilar lymph adenopathy, which we can take biopsy from, ongoing inflammation detected by PET scanning or gallium scanning, and anatomical mapping may guide us during autopsy to take the targeted area which carry fibrosis. And lastly, regarding sudden cardiac death, about 10% of patients have manifest cardiac sarcoidosis, will have sudden cardiac arrest within 5 years. And this raised the question, do we have any tools to risk stratify those patients for early intervention? Actually, as Dr. Ahmed said, the extent of scar is a tool. In one study, presence of less than 6% of late gadolinium enhancement has negative predictive value of 91%. أيضا electrophysiological testing. If it is positive, it will carry a lot of values. Those patients with positive program electrical stimulation causing sustained ventricular tachycardia will have much higher frequency of ventricular tachycardia, and those with negative EB study unlikely to have ventricular tachycardia later on. And in this more recent study, using electrophysiological testing for sudden cardiac death risk stratification in patients with cardiac sarcoidosis, we have negative predictive value of 100%, which is very high. Based on this, the guidelines recommend inducible sustained monomorphic ventricular tachycardia may carry class 2E indication for implantation of cardiac defibrillator, and I will end by this elegant registry which was carried on Finland, analyzed about 400 patients. Half of them were diagnosed as cardiac sarcoidosis by endomyocardial biopsy, the other half by extra cardiac. Those with class 1 and class 2 indication for ICD were implanted, and follow-up of those patients. This figure shows that sarcoidosis on the rise. In the last 5 years, the recently diagnosed cases nearly equal to the diagnosed cases over the preceding 2 decades. That's not because there is a break in cardiac sarcoidosis, but we have more accurate tools for diagnosis of cardiac sarcoidosis. And here how the patients were presented. Most of them presented by atrioventricular block, heart failure, sudden cardiac death, and ventricular tachycardia were also common. But unfortunately, 2/3 of patients presented by sudden cardiac death were misdiagnosed, or this were their first presentation. And regarding the cumulative effect, at 5 years follow-up, those with indication of cardiac defibrillator have sudden cardiac death, about 11% of them. Those without an indication developed sudden cardiac arrest in 5% of patients, which is high. Moreover, on 5 years follow-up, about 50% of patients, that means the half nearly, within the end of the 5 years, they have sudden cardiac arrest, sustained ventricular arrhythmia, or emergent indication, either class 1 or class 2 indication for implantable cardiac defibrillator. So the conclusion of the registry was that no guidelines can distinguish truly low risk group of patients with clinically manifest cardiac sarcoidosis. And I know it looks hopeless, but the hope is with Dr. Haitham Badran to take home message, the cardiac electrophysiologist, essential member of cardiac sarcoidosis. It may mimic arrhythmogenic RV cardiomyopathy. Sarcoidosis-related heart block and arrhythmia can reverse with immunosuppression. And finally, the predictors of sudden cardiac death include LV and RV systolic dysfunction, extent of the scar, presence of indication for pacing, sustained VT or induction of VT by programmed electrical stimulation. Thank you.
ألف شكر يا دكتور محمد. Very nice topic. في أي أسئلة؟
We have a lot of immunosuppressive therapy.
Unfortunately, in our country, patient always present late where there is no can be done.
We have extensive immunosuppression. Most of the studies are not. Especially when the heart is
Yeah, it needs early suspicion.
Definitely, yes. Okay. No comment. طب لسه اتفضل يا دكتور.
Is immunosuppressive drugs can prevent progression or starting of cardiac
Not a total prevention, but can suppress the progression of the disease.
Yeah, I mean if I start prednisone,
As
for
Dr.
example,
Ahmed
for
said, if you start
for extra cardiac symptoms for symptomatic patient.
Actually, it does suppress the progression of the disease, which they actually the human phase, which is that. Not only that, actually, the immune system actually responding even after clearance of the antigen. There are few cases that they already have a hard stamp, and the antigen has already cleared, and they are simply immune suppressed. They develop repeat cardiac sarcoidosis in a transplant thought. So it is difficult, but kind of like the immune system is overreactive even in the absence of antigen. Right? You catch it early and you get good immune suppression. You're basically preventing the inflammation from progressing into an extensive scar.
أنا مش عارفة، عايزة أسأل سؤال على جنب كده. ال percentage of affection with sarcoidosis, cardiac sarcoidosis عالية، موجودة في مصر أو في US عالية ولا؟
Depend on so the prevalence of the disease range from 1 to 35,000 individuals. So the highest incidence in the United States, African American, and Scandinavian origin.
اه
And most of the patients actually they don't even know if they are Scandinavian origin. Like,
yes
not a part. Like,
Yeah.
they are white American and they don't move from Europe or from Switzerland.
yeah.
So it ranges between 1 to 35 prevalence in 10,000.
in 10,000. وفي مصر ما عندناش أي incidence.
احنا ما عندناش
مش عارف.
ريجستري نقدر نحدد بيها الانسيدنت.
Okay. Thank you very much, Dr. Muhammad. Our next speaker, Dr. Haitham Badran. اتكلمنا عن the role of implantable devices and catheter ablation of ventricular tachycardia in patients with cardiac sarcoidosis.
Thank you very much. It's my pleasure. بس actually هو سامي قال كل حاجة. احنا ما فيش there is no slides we can wrap up the session. So I will go rapidly through some important electrophysiological points regarding sarcoidosis. Most of the things I will say, like Muhammad said in the previous presentation. So the pathogenesis of cardiac sarcoidosis, you already gone through this. It's abnormal immune reaction to unknown antigen, triggering non-caseating granuloma, and then we have an active inflammation phase, later on scar formation, and both of these phases can cause electrophysiological abnormality in the form of arrhythmias, VTAC, PVCs, or even heart blocks. So we have abnormal electrophysiological presentation from the early beginning of the disease or the cardiac involvement till the later phase of the scar formation. And actually, the cardiac cause of death representing something like 35% of the total mortality of the patient with sarcoidosis, and 38% of these are ventricular tachycardia or sudden cardiac death, 50% heart failure manifestation, and 12% are others. And of course, the involvement of the cardiac muscle within the sarcoidosis, I think it accelerates the mortality or make the prognosis very bad in comparison to the extracardiac sarcoidosis manifestation. So the electrophysiological manifestations may vary. It can start with a high-grade AV block in a very young age. This is the most common first presentation, followed by heart failure, fatal or aborted sudden cardiac death, sustained ventricular tachycardia, and we can see some SVT, mainly atrial fibrillation, as Sami said, and this is because of course of increase of the atrial pressure and some scars and fibrosis within the left atrium, and this will represent something like 32% in the patients with sarcoidosis. In asymptomatic patients with Holter, we can find that something like 5% AV block, 4% sustained ventricular tachycardia, and 34% of non-sustained VT. Moreover, we have something like 20 to 30% fatal ventricular arrhythmia incidence in 5 to 10 years in the patients who were previously asymptomatic. So I think if the patient present with any symptoms of the cardiac involvement and we're gonna implant a device anyway, I think an ICD will be very reasonable for this patient rather than a pacemaker. So we'll go through the pacing in cardiac sarcoidosis, when to pace. Actually, it's the same like patients without sarcoidosis. We'll pace when you have a high-grade AV block, but actually the guidelines state that even if the AV block is reversible with the immunosuppressive or with the steroids, you should implant a pacemaker because it's unpredictable when it will be reversible and when it will recur again regarding the AV block. So it indicates when you have an AV block high grade, place a pacemaker for this patient, or you can place an ICD because 20 to 30% of these patients will develop later on ventricular arrhythmias, fatal ventricular arrhythmias. So implanting ICD is a class 2 indication actually without a clear indication for an ICD, but only indication for pacing. The CRT, when the patient ejection fraction is below 50, like the BioPace trial, but actually the response of the patient with the CRT is very poor, and this is because of the extensive scars or fibrosis, and the response rate is something like 41% in comparison to 70% in the other population. And this is when to implant an ICD for our patient. This is some sort of the American guidelines 2017. If it's a secondary prevention, of course it's a class 1 if the patient has a sustained ventricular arrhythmia, including prior cardiac arrest or survival of sudden cardiac death. ICD is a class 1 recommendation. If the ejection fraction is below 35%, it's also a class 1 like the ischemic cardiomyopathy or dilated cardiomyopathy. If the patient has a syncope and the ejection fraction is something between 35 to 50, it's reasonable to implant an ICD as well. So the patient with confirmed diagnosis of sarcoidosis and unexplained syncope, it could be some sort of malignant arrhythmia, so ICD is a class 2A indication. Indication for permanent pacing, as I said, you should implant an ICD as well. If you have an inducible ventricular arrhythmia by programmed electrical stimulation, like Sami said in the previous presentation, it might be indication to implant an ICD as a class 2A recommendation. If the ejection fraction is something between 36 and 49, which is the mid-range heart failure, the RV ejection fraction is depressed below 40% despite optimal naked therapy, and then you have some sort of extensive scars in the CMR with the late gadolinium enhancement, of course, or you did an electrophysiological study with VTAC induction, you might implant an ICD as a class 2B. If not, do an MRI. If you find an extensive scars like more than 6% late gadolinium enhancement LV, ICD can be useful in these patients as well. So we have a very low threshold to implant ICD in these patients because the incidence of ventricular arrhythmia and fatal sudden cardiac death is very high, despite he might be not indicated to implant an ICD if he hasn't sarcoidosis, of course. So this is regarding implantation of a device. In my practice, I have been practicing cardiology since something like 20 years, two of them in Germany, but I didn't implant a device for a sarcoidosis patient. But actually the guidelines said that implantation of sarcoidosis devices actually associated with more complication than normal individuals, mainly infection because of the immunosuppressive drugs they are taking, of course, and with some lead dislodgement. This was a small trial or small registry, showed that they are associated in comparison to the normal individual with some lead dislodgements more than the normal individual. Infection rate is higher than normal individuals, of course. Regarding the ablation of ventricular tachyarrhythmia associated with cardiac sarcoidosis, we have a very high recurrence rate because of the patchy affection or the scars which are heterogeneous inside the myocardium. So it's not easy to encircle the scar or to cut the isthmus where the tachycardia goes in the re-entry circuit, of course, in the chronic phase. Active inflammation at the baseline detected by the PET scan is associated with the increased risk of recurrent VT following catheter ablation, because in the active state it's some sort of edema. So you are not able to deliver the therapy very effectively because of the edema, will insulate and the heating will not be reached to the myocardium where we aim to ablate. And actually, you know the extent of the scar after resolving with this edema, what it will be like. It is recommended to treat the active disease phase with immunosuppressive at first, and then attempting catheter ablation later on. The outcome after ablation is different according to the ejection fraction. If the ejection fraction be above 50%, actually it carries more or less a better prognosis and less recurrence in comparison to less than 50%, and the presence of inflammation as well could be with a better prognosis, but the recurrence is higher. So this is to summarize how to manage ventricular arrhythmia in cardiac sarcoidosis. Of course, the first line therapy is immunosuppressive, or the first in timing is the immunosuppressive drugs. Steroids can resolve the AV block in some patients and can resolve the edema, of course. Immunosuppression is recommended if there is evidence of active inflammation in the cardiac MRI or PET-CT. ICD implantation, as I mentioned, is a class 1 as a secondary prevention in sustained VT or survival of sudden cardiac death, ejection fraction below 35%. It's a class 2 indication if the patient has a syncope or VTAC in the programmed electrical stimulation, myocardial extensive scar more than 60% in the cardiac MRI, indication for permanent pacing. This is class 2 indication. Catheter ablation, associated with high recurrence, as I mentioned, because of the challenge substrate and the heterogeneous scar we have, recommended to treat active inflammation prior to attempting catheter ablation in these patients. The amiodarone, or the antiarrhythmic drug, is often used as a first-line antiarrhythmic in these patients, of course, but the effect is not very good with a very high recurrence rate. And it's used in combination with the immunosuppressive drugs if there is an evidence of inflammation in the cardiac MRI in these patients. So my take-home message, the cardiac sarcoidosis remain a complex and challenging condition to manage. It is characterized by high burden of arrhythmic manifestation, including AV block, ventricular arrhythmia, and sudden cardiac death. Given the patchy nature of the sarcoid granulomas, utilizing three-dimensional electroanatomical mapping like the Carter system in order to direct where we'll take the biopsy for the definite diagnosis is very beneficial as well. So this is another role of the electrophysiologist in the sarcoidosis. Immunosuppression remains a key component of cardiac involvement of sarcoidosis to reduce myocardial inflammation. Some patients will require electrophysiological intervention such as device implantation, as mentioned, either pacemaker or an ICD. There is a strong evidence that advanced cardiac imaging, particularly cardiac MRI, improves sudden cardiac death risk. Sudden cardiac death stratification is valuable in guiding the use of devices. Over the coming years, we are likely to see further development of technology that will enhance our ability to treat, hopefully, to treat recurrent ventricular arrhythmia with catheter ablation. Thank you very much.
Thank you very much. A very informative lecture, Dr. Hyson. Thank you very much. في أي أسئلة؟ تفضل يا دكتور.
Yes. أنا هرجع لك للسلايد. السلايد اللي فيها class 2 indication. There is nothing regarding the ejection fraction.
But there was a syncope, I guess.
No, and or. It's and or. So if you have a syncope or prevalent pacemaker indication and or programmed electrical stimulation. So if the patient with any symptom, syncope, dizziness, or something with normal ejection fraction, you just do a programmed electrical stimulation, then implant a device if it's possible.
My question is, if the patient have asymptomatic with cardiac involvement, is there a rule for to prevent sudden cardiac death? As it
no, I mean, to my knowledge, no. But I mean, how would you diagnose the patient in Egypt with cardiac sarcoidosis without symptoms?
يعني patient diagnosed as sarcoidosis.
No, for the sarcoidosis patient, no, it's not indicated. It's only for the cardiac involvement, and you have to diagnose first.
Well,
Yeah. Even with an Holter, if you diagnose with a Holter or something like this, if you have skin lesions of sarcoidosis, of course.
You will give an alarm.
Any more questions? No?
Thank you.
Okay, thank you, Dr. هيثم. ألف شكر.
بص حضرتك هو احنا
معاكي المايك يا دكتورة، معاكي المايك.
No, I'm not questioning it. It's just that, you know. Yeah. Yeah, I just want to, you know, is this really was a big deal or not? That's my whole question, you know.
لسه في our last question. طيب our next speaker دكتور ياسر علاء الدين من عين شمس talking about the multidisciplinary approach in the management of cardiac sarcoidosis involving cardiology, pulmonology, rheumatology and pathology. اتفضل يا دكتور.
Thank you for the dear
kind invitation for this distinguished conference. I'll talk about a multidisciplinary management approach for sarcoidosis. My agenda will talk about introduction, pathophysiology, how to diagnose and how to screen for cardiac sarcoidosis, and for a multidisciplinary management approach. First of all, we have to recall that the modern history of sarcoidosis goes back to 1899, when pioneering Norwegian dermatologist Cesar Bock coined the term, this term about the skin nodules characterized by compact, sharply defined foci of epithelioid cells with large pale nuclei and also a few giant cells and resembling sarcoma. That's why he called it this multiple benign sarcoid of the skin. We have to remember that sarcoidosis is an enigmatic disease or a mysterious disease for many reasons, not at least due to its exact cause is unknown, but also it can affect many organs, including the heart. The heart is involved in up to 25% of sarcoidosis patients. In rare cases, the heart may be the only organ involved, and the patient, if symptomatic for cardiac sarcoidosis, actually has a very poor prognosis. The diagnosis is very challenging. However, in the last decade, we have several guidance to manage the patients. Next. And the cornerstone of management of these patients is a multidisciplinary team approach involving collaboration of cardiologists, pulmonologists, radiologists, rheumatologists, and other specialties. What about the pathogenesis? We have to have a further look on pathogenesis in depth. The hallmark of the disease, as we know, it's a compact epithelioid non-necrotizing granuloma with varying degrees of lymphocytic inflammation. And according to the New England Journal of Medicine and the JACC recently published, the overarching hypothesis involves three factors. We have environmental antigens, whether infectious, occupation, or others, that triggers, number two, a dysregulated T-cell driven immunological response in a genetically predisposed patient. And we have also, this leads to the presence of non-necrotizing inflammatory granulomas that may disappear spontaneously or lead to local injury and subsequent fibrosis. And we have a genetic background predisposing the patient to the development of sarcoidosis. Next. The histologic hallmark of sarcoidosis thereafter is a dysregulated antigenic response to unknown environmental exposure in a genetically susceptible person. This is the proposed concept for granuloma formation. We have unknown antigen presenting to the dendritic cell and macrophages that act as antigen presenting cells that promotes present the antigen to the T cells, mainly the T helper 1 cells, and we have change in the M1 macrophage into epithelioid cells that fuse together to form the multinucleated giant cells, and we have also a transition from the macrophage from M1 to M2 and T helper 1 to T helper 2. This leads to either clearance of the antigen or with persistent development of the sarcoid disease. And this is the granuloma formed. What about the clinical manifestations? Involve several organs. Several organs are involved. Mainly it can cause uveitis, pulmonary symptoms. Also, it can cause interstitial nephritis and advanced heart block. What about the cardiac sarcoidosis? Regarding the cardiac sarcoidosis, we have several clinical features in the skin: lupus perennial, vitiligo, erythema nodosum, especially in Scandinavians, multinucleated macrophages, diagnostic features in the CT chest. Also, we have, as mentioned before, the cardiac involvement demonstrated by the PET scan or MRI, and also new sarcoidosis and the pathology. What about the cardiac sarcoidosis? In up to 5% of patients with pulmonary sarcoidosis, it's clinically manifest in about 5%. may be silent up to 25%. And also in Finland, as mentioned before, the diagnosis has increased about 20 folds, and in the US, from patients undergoing transplantation, the incidence of sarcoidosis increased from 0.1% up to 0.5%. The disease involved the myocardium early small patches in the basal septum, the clinical silent, with the extension of the disease, it can cause heart block, ventricular arrhythmias, and subsequently, ultimately, cause heart failure. The phenotypes of cardiac sarcoidosis, according to the European Journal of Heart, demonstrate 3 phenotypes: cardiac sarcoidosis until autopsy, without symptoms, diagnosed after sudden cardiac death during autopsy, and also cardiac sarcoidosis with dominant extracardiac sarcoidosis with no or minimal cardiac symptoms, and lastly, the clinically manifest cardiac sarcoidosis. We have various symptoms: dyspnea, palpitation, syncope, high-grade AV block or VT, and also some clues in the echo like LV dysfunction, wall filling, especially the basal interventricular septum with reduction of the global longitudinal strain and RV involvement. I will not mention the CMR scintigraphy, FDG, and endomyocardial biopsy that can aid in establishing the diagnosis. But we have to differentiate cardiac sarcoidosis from myocarditis, as mentioned, and also from the arrhythmogenic RV cardiomyopathy. What about the diagnostic criteria? We have 3 expert consensus. Number 1, the Heart Rhythm Society expert consensus that demonstrate 2 pathways, either histologic pathway, that we have to have a biopsy from the myocardium, demonstrate non-carcinogenic granuloma in the myocardial tissue, and also to demonstrate no other alternative cause identified. What about the clinical pathway? We have to demonstrate also a biopsy from extracardiac tissue, which is positive for the diagnosis. No other reasonably other cause is evident, and also establishing one of the following: steroid responsive cardiomyopathy or heart block, unexplained reduction in LV ejection fraction, unexplained VT or high-grade AV block, and also characteristic patterns on cardiac imaging. We have the Japanese Society of Sarcoidosis, as I have mentioned. We have to establish histological pathway, non-carcinogenic granuloma in the myocardial tissue, plus histological or clinical diagnosis for extracardiac sarcoidosis. What about the clinical pathway? We have to demonstrate extracardiac sarcoidosis in addition at least 2 major or 1 major and 2 minor criteria. Lastly, we have the World Association of Sarcoidosis that demonstrate high probability of sarcoidosis by demonstrating biopsy of the organ without any alternative cause, or at least probable, as mentioned before, accordingly treatment responsive cardiomyopathy or AV block, and the same criteria. Lately, there is a direction for precision medicine, like the slogan of the conference for artificial intelligence. We are gathering the data into an imaging biobank and also a molecular biobank in order to give machine learning, and according to the AI, we can discover any biomarker that can truly differentiate patients that are diagnosed for sarcoidosis from unlikely to have sarcoidosis. This is the most important slide. We have to have a high index of suspicion. Any patient with documented extracardiac sarcoidosis, he has to undergo to search for cardiac affection through history, physical examination, ECG, Holter, and echo. If all of these are negative, we have to follow up on regular visits or once a year to undergo to make Holter and echo. If any of the above is abnormal, we have to perform CMR or PET scan to confirm the diagnosis of cardiac sarcoidosis. What about patients without known sarcoidosis? If we have a patient below 60 years with no prior history of sarcoidosis, and we have a high-grade AV block, sustained VT, or heart failure without any other trigger, we have to do a chest high-resolution CT and CMR and or PET scan. If the high-resolution CT demonstrates signs of pulmonary sarcoidosis, or B, the CMR or PET scan showing signs of cardiac sarcoidosis, the cardiac sarcoidosis is likely. If both are negative, then thus sarcoidosis is unlikely to be. And this is a red flags for cardiac sarcoidosis that has been developed through several criteria: sudden cardiac death, tachycardia-induced cardiomyopathy, through ECG criteria, echo, and CMR, and also FDG and CT. And we have to develop the patient-centered care. Why do we care? Increase mortality and morbidity. Any physician may be the point person. As we have demonstrated, we have to take care about extracardiac affection in order to establish the diagnosis. In general, the treatment approach, there is no causal treatment for sarcoidosis proposed to date. The primarily treatment should focus upon reducing inflammatory activity and prevention of fibrosis, with the key role played by corticosteroid. We start with high dose prednisone, then gradual tapering over 1 year, and we can continue with a low dose thereafter. If no adequate response to corticosteroid, we'll shift to corticosteroid sparing agents like methotrexate and azathioprine and hydroxychloroquine. The multidisciplinary team consideration should focus on the other than pulmonary and cardiac affection, like the brain, eyes, or kidneys, the presence of pulmonary hypertension, reduced lung function, and pulmonary fibrosis. And also, it has been demonstrated that sarcoidosis-associated fatigue, a symptom associated with a specific organ manifestation, and small fiber neuropathy is very important in the management. What about cardiac sarcoidosis? We have myocardial involvement that can easily managed by anti-inflammatory therapy. And also, we have the arrhythmia, as mentioned by our previous colleagues, through device management and anti-inflammatory therapy. We have several stepwise approach: glucocorticoids, first line; second line, methotrexate, azathioprine; then the third line, infliximab, adalimumab, targeting tumor necrosis factor alpha, and also the rituximab, heading the B lymphocytes. Fourth line, we have the JAK2 inhibitor, and also the ACTH that can be given parenterally. This is for pulmonary sarcoidosis, the same management, and also the new sarcoidosis. What about the sarcoidosis-associated fatigue? We can add exercise training and inspiratory muscle training in addition to other medications. What about for the neuropathy? We can add GABA analogs, antidepressants, and also other symptomatic treatments like tramadol and other topical agents. Lastly, the skin sarcoidosis, we are mainly concentrating upon hydroxychloroquine and or chloroquine. Cardiac sarcoidosis, in the end, in a nutshell, its pathogenesis is unknown, environmental triggers, genetically predisposed, granuloma leading to fibrotic scarring, main manifestation subclinical cardiomyopathy, AV blocks, VT, heart failure. We have diagnostic biopsy, diagnostic imaging tools. The therapy includes tiered immunosuppression, treatment of arrhythmia and heart failure, consideration of an ICD to prevent sudden cardiac death. My talk message: the suspicion should always emerge in patients with extracardiac disease who present with cardiac signs and symptoms. And also, it's prudent to consider the findings of unexplained second or third degree AV block, sustained VT, or the presence of heart failure with ventricular dysfunction with exclusion of ischemic or Chagas disease. In the end, the cornerstone of the management of this patient is a multidisciplinary team approach involving collaboration for the cardiologist, pulmonologist, radiologist, rheumatologist, and other specialties. And thank you for your attention.
شكرا يا دكتور ياسر. يا ترى في أي تعليق أو أي سؤال من حضراتكم؟ طيب احنا هنراب اب بقى. ميرسي يا دكتور. ثانك يو فيري ماتش. دكتورة مروة هتراب اب هير كيس اللي قدمتها في الأول خالص. اتفضل.
First we will revise the ECG.
صوتك بقى يا دكتورة مروة.
ECG showed AV dissociation and changeable axis. And this is first AVR is positive, and if we maximize chest myocardial leads, there is AV dissociation seen in V3 and V2. the picture is ما هي الفكرة صور revisable. AVR both negative.
It was 150 exactly.
It's a flutter probably with a bundle branch يعني. it looks like a flutter طبعا يعني we are not sure 100% يعني نقيسه ونبص عليه يعني بس it looks like a flutter with a bundle entry.
The picture
بقية الchest leads فين؟
بس انا عايزه الصورة.
And you thinking this is a P waves؟ اللي هي the terminal part. I'm not that sure يعني بس المنظر بتاع lead 1 ده والريت ده it looks like flutter with a bundle branch. Yeah, bundle rather than a VTAC. It looks like flutter بس يعني it's a wide complex tachycardia anyway so I'm not sure.
I'm sorry, Marwa, we know it's an introduction for the discussion. It's not like we're arguing diagnosis or anything, but I don't know where you see the P wave, honestly. So,
هي مروه شك ان دي قد تكون P wave دي مش كده؟
Yeah, but this is the only one you see.
بس في حاجات شبهها هنا وهنا في حاجات شبهها في حتة تانية. انا معاكي بس في حاجات it looks like a P wave هنا برضو. I'm not sure يعني ممكن يبقى ده من الباندل ارتيفاكت العامل كده كله او يعني الليت سيجنال افريج في الاي سي جي يعني اشاور. طب ممكن باين عندكم السهم؟ طيب احنا عندنا حاجات it could be a P wave retrograde وساعتها هيبقى dissociated يبقى ventricular tachycardia بس it could be some sort of terminal deflection في الكومبلكس وده very common مع العيانين اللي عندهم يعني myocardial involvement عامة. could be مش definite diagnose بس المنظر بتاع lead 1 ومنظر البندل برانش ده it looks like انه flutter مع بندل بس يعني the same.
Not definite diagnosis.
It's not definite طبعا.
For each study.
For each study.
إذا حضرتك.
اوكي. اوكي ماشي.
So the aim of our case it is to يعني offer a live example to apply a diagnostic algorithm not to jump to a definite diagnosis. Sarcoidosis يعني already is a difficult to diagnose but to keep sarcoidosis in our minds just.
It's fun. Let's just say. Well, let's go back to this one. Until I agree with this. But would you give this patient steroid? Would you give this patient steroid therapy?
ياخد ستيرويد؟ جلوكوكورتيكويد بالتحديد.
already received corticosteroids with
Based on what diagnosis?
أول حاجة.
ممكن خد عنده أنا ما حضرتش بس
so we are in front of a patient with
there are some lymph nodes in the mediastinum, but no tissue type, no extra, no extra pulmonary, no extra cardiac diagnosis.
So, in patient, to wrap up our patient, there is a ventricular arrhythmia, mediastinal lymphadenopathy, history of facial palsy, panuveitis, skin lesions, responding to corticosteroids, and cardiac MRI with patchy area of fibrosis and edema.
No, wait a minute. You did not do T2 study. You did not have a 2T. I did not see a T2 study on the MRI. You just did late gadolinium enhancement. Late gadolinium is a scar tissue.
T1 and T2 protocol.
Okay, yeah.
Show patch area of the high signal
Mainly, it's just like the 2T is more anti-reverse. 2T is more than 2T is more T2 is more important than the T1.
مروه انت كارديولوجيست وقصدي والكتروفيزيولوجيست؟ طيب ماشي اوكي.
طيب sarcoidosis يعني our aim in this case to emphasize that sarcoidosis is a possible diagnosis. Keep it in your mind. And to diagnose the sarcoidosis, there is multiple points to be collected, as mentioned in our lecture by our professors. An unexplained heart block should trigger isolated sarcoidosis, يعني keep it in mind. Responsive to early immunosuppression is a sign. It may be sarcoidosis treated with CRT ejection fraction less than 50%. Although ICD recommendation is not fully recommended in low risk patient, but and our patient as he has ventricular arrhythmia, so it is recommended for ICD implantation as secondary prevention. In this case, after to be sure diagnosis of this Elizabeth D. Thank you.
Thank you.